Good evening, friends. I'm Dr. Nitin. I'll be speaking about bladder issues leading to chronic kidney disease in children. A little about myself. I'm a pediatric nephrologist at NU Hospitals, Bangalore. I have done my education from Sri Devaraja's Medical College, Kolar, from MS Ramaya Medical College, Bangalore, and did my DNB pediatrics from Rainbow Children's Hospital, Hyderabad, with a fellowship in pediatric nephrology from St. John's Medical College, Bangalore. Uh, I've been member of various pediatric and pediatric nephrology associations, as you can see, and I am basically a pediatrician who has a special interest in pediatric nephrology conditions. I've been working with the new hospitals for the past 4 years. So I'd be talking about bladder issues in primarily in children, and as an extrapolation, similar kind of issues do occur in adult as well. So we have two kidneys, just going to the anatomy of it, two kidneys draining through the ureters, and the urine goes into the bladder, and then there's a outlet, bladder outlet, a tube called the urethra through which the urine is expelled. So the bladder has a dome-like shape, and the two ureters enter through the side of the bladder, and there's a muscle layer of the bladder through which the ureters tunnel before they open into the bladder wall. And this is the bladder. The muscle of the bladder is called the detrusor, which contracts to expel the urine. And when the bladder is filling, the muscle needs to relax. And there's also another muscle called the pelvic floor here, which acts as a sphincter or a valve-like mechanism. It needs to be shut when the bladder is filling, and when the bladder is emptying, the pelvic floor has to relax. So, what are the functions of the urinary bladder? So, it functions as a receptacle. It stores urine so that the voiding can be controlled. It can be infrequent, and the bladder is lined by a muscle layer which can stretch to hold urine. In the adult, the normal capacity is around 400 to 600 ml. In children, it varies with age. So during urination, the bladder muscles squeeze, and the two sphincters, the upper sphincter valve and the lower valve, open to allow the urine to flow. So the urine exits the bladder through the urethra, which carries the urine out. So when the bladder is filling, the sphincter and the valve mechanism needs to be closed, the pelvic floor has to contract, and the detrusor muscle has to relax. The reverse happens when the bladder is contracting and the person is passing urine. So, all this is controlled by a nervous system. There is something called a sympathetic nervous system, a parasympathetic nervous system, and the voluntary voluntary nerves, the somatic nerves that control the pelvic floor. So all these three systems need to work in coordination to have an effective bladder emptying. On top of that, there's the brain, which exerts a kind of voluntary control over the voiding mechanisms. So coming to bladder issues per se, there could be structural issues or functional problems. By structure, I mean a smaller capacity bladder or a malformed bladder, something like when there's a defect in the abdominal wall and the bladder is open. So all these are structural abnormalities. And then there are functional abnormalities where the bladder is not able to empty effectively. So this could be because of a neurological problem, like a child with a cerebral palsy or some other neurological conditions, or it could be an acquired or a behavioral issue in a child, because of which he holds urine for too long and doesn't empty completely. So the symptoms of a bladder issue could be it could be categorized as either storage or elimination. By storage, we mean he is not able to store urine or hold urine in the bladder. So this couldn't happen when the bladder is overactive, and when the patient will have an urge incontinence. Also, there could be issues like stress incontinence or giggle whenever the patient strains, he tends to pass urine, and extraordinary daytime frequency. Elimination issues could be like dysfunctional voiding, holding up urine for too long, passing in small amounts, not emptying the bladder completely. There could be some obstruction to the flow of urine, or there could be reflux, that is movement of urine into some other passage. So now coming to the structural problems, there could be something called a posterior urethral valve. This is a congenital abnormality that is present by birth and exclusively in boys. There's a membranous fold at the junction of the bladder and the urethra, which normally needs to involute and disappear. It does not disappear in certain children, so it kind of obstructs the passage of urine. So the patient is not able to void completely. There's a obstruction to the flow of the urine, and his urine flow will be poor. There will be a lot of distension of the bladder, filling up of the bladder, a lot of pressure generated within the bladder, and the backflow of urine through the ureters. The other issue that we see is of this reflux. Like I mentioned, there's a valve mechanism at the junction where the ureter meets the bladder. So the urine should normally flow downwards into the bladder, but not back into the ureters. So when this valve mechanism fails, there is back leak of urine towards the kidney. So this fills up the ureter, and then it distends even up to the kidney and can cause pressure effects and damage to the kidney. So with long-term reflux, there is a lot of pressure and damage to the kidneys. Also, there is a risk of infection spreading from the bladder to the kidney, causing a kidney infection, something we call pyelonephritis. And each time there's an episode of pyelonephritis, there's a scar that develops in the kidney. And scar is a tissue that doesn't function, and once a scar is formed, it is irreversible. So the kidney function progressively declines. There's another entity which is dysfunctional elimination syndrome, where the patient neither moves bowel properly nor empties his bladder completely. So this is by and large a behavioral pattern. The patient holds stool for a long time. There is constipation, and in trying not to pass stool in inappropriate situations, there's pelvic floor overactivity, and then as a result, there's dysfunction of the bladder, one contributing to the other, and there's retention of both stool and urine. So to break the chain, we need to have a proper bowel management, a high fiber diet, adequate fluid intake, probably some laxatives sometimes, and also the bladder management in terms of time voiding and hydrotherapy, fluid management. Such patients will also require psychological support, education about normal bladder function, adequate fiber intake, and optimizing the toilet routines. Sometimes your bladder can be overactive. So if there's some bladder irritation because of preservatives in the diet, or if the urine is super concentrated, or if there's constipation, then there's irritability of the bladder muscle. It keeps contracting even when the bladder is filling. So in such cases, the urine tends to leak even during the filling phase, like I show in this diagram. And then there is the spinal injury. So when there is a spinal injury due to some trauma, depending on the level of the spinal injury, the bladder could be a hyperreactive bladder, like a spastic bladder, which stays in a state of contraction, or a flaccid bladder that does not contract at all and tends to retain urine, get repeatedly infected. These are the issues that we commonly encounter. So how do we manage it? It is by optimizing the fluid intake, limiting the caffeinated drink and alcohol intake, and frequently emptying the bladder, either by intermittent self-catheterization or having a urinary diversion. And whenever there's a sign of a urinary infection, we need to treat it promptly. So the management of neurogenic bladder is primarily by using medications, and on top of that, we could use CIC, or clean intermittent self-catheterization. If that doesn't work, or if it is refractory, if it's still generating a lot of pressures, then we need to do a bladder augmentation. we need to increase the bladder capacity by attaching a piece of coal onto it. Evaluation includes simple investigations like an X-ray, erect X-ray abdomen, which would give a lot of information, or an ultrasound, which gives a lot of information about the size of the bladder, the shape, and all those things. And certain specific tests like uroflowmetry, which gives an idea about the flow of urine, the peak flow, the time to emptying the bladder, and urodynamics, which gives a pressure volume curve. So what are the measures available for bladder control? There are certain medications that could be used, like alpha blockers or anticholinergics. Hydrotherapy, that is stipulating the amount of fluid intake that could be allowed, time voiding, double voiding strategies where the patient is guided in strategies how to empty the bladder completely. And there is clean intermittent self-catheterization, where the patient uses a catheter to catheterize himself and empties the urine each time at regular intervals. If these fail, then there are bladder augmentation procedures to increase the capacity of the bladder, or a urinary diversion through which the urine could be removed effectively. So if the bladder is not effectively managed, then there is a progressive deterioration of the kidney function. And as the kidney function deteriorates to below 15%, they reach something called a stage 5 or end stage renal disease. So the take home messages in my talk are that various bladder disorders affect the kidney indirectly to cause worsening of kidney function. With prompt management of bladder problems, the deterioration of kidney function can be halted or slowed down. And in a patient with bladder issues and chronic kidney disease requiring renal transplantation, the bladder problems need to be tackled first prior to going for the renal transplantation. Or else, when the graft is placed, the bladder problems persist, they can affect the graft as well. So, thank you. This is